Hello guys, this is another beautiful afternoon whereby I'm going to continue presenting to you on obstetric emergencies. Today I would like we discuss more on antepartum heamorrhage, that is APH. And antepartum heamorrhage or APH is also known as prepartum heamorrhage. Prepartum heamorrhage. Let's try to define what is prepartum heamorrhage. And by definition, we are saying this is bleeding from genital tract after 24 weeks of gestation, mark 24 weeks of gestation, in late pregnancy, and before onset of second stage of labor, or rather, or before onset of labor. And we are saying prepartum heamorrhage is more common in multiparous than primigravidas. The reason is because of the myometrium muscles in primigravidas are more they are rigid as opposed to those of multiparous, which have relaxed because of frequent giving of birth. Why are we saying antepartum heamorrhage is an obstetric emergency? What is the rationale can we give? What is the reason behind all this one? And we are saying it's an obstetric emergency because of the risk of hypovolemia, especially which is associated with the placenta, and that is how we can be able to describe or to define prepartum heamorrhage. Let's see classification, or rather major causes of antepartum heamorrhage. And we can say they are basically based on the specific site of heamorrhage. Where is the blood coming from? Remember we said it's actually from the genital tract, but we need to get about the site of heamorrhage and also the location of the placenta. That is number one. And therefore we can basically say the causes of antepartum heamorrhage is basically classified into three, or rather into four. Some books they normally talk about three, others they talk about four causes or major classification of antepartum heamorrhage. Number one, we try to say it is what we call placenta previa. We shall see what is placenta previa is by description. What is placenta previa can be, because it's basically about where is the placenta situated or where is the placenta located. We go back again to normal labor, normal pregnancy. We said in normal pregnancy, the placenta is always located in the upper uterine segment, or rather posterior of the uterus. But now in this case, the placenta is actually located in the lower uterine segment. That is what we call placenta previa. The other one is placenta abruption or abruptio placentae. What is the risk when you see the placenta separating early, even before the onset of labor? Now that is what we call placenta previa. Number three, we can talk about incidental or unclassified all extraplacental bleeding. When we talk about incidental, unclassified, all extraplacental bleeding, this is where we talk things like cervicitis, maybe laceration from the vagina, tumors of the vagina, marginal show. Those are, we call them unclassified. Then some books they talk about the fourth major causes of APH as vasa previa. And the vasa previa we actually trying to say is actually bleeding from the fetal, ruptured fetal membranes. And this membrane we are trying to talk about, that is the chorion and the amnion. Basically, when we talk about on these causes of bleeding in late pregnancy in regards to placenta previa, we are trying to say the most common cause of this placenta previa, it is of the APH, it is placenta previa, followed by placenta abruption, and then unclassified. That is how we can be able to talk. So let's try to talk about placenta previa. In placenta previa, we are trying to say is also referred to as unavoidable antepartum hemorrhage, something that you cannot avoid. It just has to come. And when you check about the description of the placenta previa, we are saying this is a situation where the placenta is either partially or partly all whole, embedded. Embedded means located in the lower uterine segment, either anteriorly or posteriorly. And when you talk about partially all whole, what do we mean? You as a midwife, you should be able to understand these simple terms. Partially all whole. Partially means this placenta, majority of the placenta is actually on the upper uterine segment, but only small tissues which is actually found on the internal hose. That is partially, all partly. But if you talk about whole, this means the whole placenta is actually embedded on the lower uterine segment, that is actually at the internal cervical hose. Therefore, we are saying normally as a segment normally prepares for the labor of the labor process. Which segment are we trying to do? We go back again to physiology of first stage of labor, and we try to ask ourselves, what does the polarity means? And we know polarity is the neuromuscular hormone that prevails between the upper uterine segment and the lower uterine segment. What is the role of the upper uterine segment? What is the role of the lower uterine segment? We know as the cervical effacement takes place, the upper uterine segment, the role, it is to shorten. Then as the upper uterine segment shortens, the whole cervix is being taken up. What does the lower uterine segment does? It lengthens. When it is lengthened, it brings about what we call cervical dilatation. And that's why we are trying to say, what is the role of this lower uterine segment? It is to prepare the labor process. Partial separation or normally occurs, then can lead to bleeding. So we ask ourselves, what causes the placenta to get implanted, or rather embedded in the lower uterine segment? There are so many causes. Number one, we are talking about grand multiparity. Grand multiparity, where are we so much interested? Grand multiparity, these are mothers who have given birth for more than 5. And what is the rationale behind mothers who are giving birth for this one? There is the upper uterine segment normally becomes scary. This scary of the upper uterine segment. Then this one they normally causes what? Failure of implantation in the early pregnancy. The other one is about the other cause is multiple pregnancy, and we know multiple pregnancy is more than 2 fetuses inside the uterus. And we are saying in multiple pregnancies could be either due to a large placenta or many placenta inside the uterus. We also talk about things like placental abnormalities, some anomalies in the placenta in cases where we have a placenta with an extra lobe or bipartite type of placenta. Then we can also have repeated dilatation and curve change. These are normally lips upper segment severely being scaled if you continue doing DC to these mothers. We can also talk about things like assisted conceptions in most cases in multiple pregnancy. Then finally, we can talk about uterine structural anomalies, some abnormalities like biconnuated uterus. Then let's try to ask ourselves, if we get a mother with placenta previa, what are the clinical features? How do these mothers normally present with? How do they, or what are the signs and the symptoms? And remember, we talked about the site of heamorrhage and the location of the placenta. Those are the things which can give us the guideline on how we can be able to get about these clinical features. Number one, we are talking about history of painless vaginal bleeding at rest. The blood is coming out and the mother is not feeling any pain. And we are saying this one is not associated with any activity. The mother is at rest. The mother is actually relaxing, and then the blood, which is painless, is also coming out. Then we ask ourselves, what is the color of this blood? The color of the blood is always actually bright red colored loss. And when we talk about bright red colored blood, this one normally signifies fresh bleeding, and it could be slightly or can be intermediate. Then when you try to check about on abdominal palpation, what is the consistency of the uterus? It's actually normal and no pain on palpation. Therefore, this means the fetal parts palpation is actually normal, though in malpresentation and abnormal lie, they are much common. We'll be able to talk about what is malpresentation and what is abnormal lie. In abnormal lie, we are trying to say, is it the unstable lie, the lie which continues to vary after 36 weeks of gestation, changes from one position, that is either longitudinal, transverse, or oblique. That is what we call the unstable lie. Then the fetal heart rate. On auscultation, we are saying the fetal heart rate, sound rate, and the rhythm are easily auscultated, and they can easily be interpreted depending on the extent of the separation. Then when you ask ourselves, the bleeding in correlation to the shock, and we know basically the type of the shock this mother is getting is what we call a hypopolemic type of shock. So shock features correlate with the amount of blood loss. That is basically the clinical features. Of something to note and to put it in your mind is that all mothers with vaginal bleeding, vaginal examination is contraindicated. You are not supposed to do VE to these mothers because of the probability of severe bleeding from further separation. So you are not supposed to do this one. Let's try to look about on clinical diagnostic features. Diagnostic features, we are asking ourselves, how do you know this mother is having an avoidable antepartum hemorrhage? There are basically two. Number one is about history and the physical examination of the findings. And in most cases, you can be able to get unstable lie, malpresentation, features of presenting parts to a gauge. We will now look at the placenta, where it's embedded, where it's located in the lower uterine segment. The baby is trying to descend so that can be delivered, but it goes and it gets what? Resistance. So that's why we are trying to say history taking and physical examination for these mothers is very, very important. Then number two, you can as a diagnostic factor, you can have radiological examination so that you can be able to confirm the diagnosis. And in most cases, this radiological examination, you normally find the placenta is actually situated in the lower uterine segment. So let's try to see the classification of the placenta previa. And we are saying classification is always actually based on how far the margin of placenta is The margin, how far the margin of the placenta is from the internal cervical horse. Let's go back again to the normal labor and try to ask ourselves, do we still remember about the structure of the cervix? We talked about we have a internal cervical horse, external cervical horse. When we mean about internal cervical horse, by description, what do we mean? When you talk about external cervical, what does it mean? Remember the structure of the uterus, where we have the neck of the uterus, where the uterus joins with the vagina. Where the uterus joins with the vagina, we try to say there is where the cervix opens to the uterus. We normally refer that one as internal cervical horse. Where the cervix opens to the vagina, we normally refer it as external cervical horse or parus horse. That is, again, you should be able to get this measurement and you know about all of them. So we go to the classification. We are trying to say in layman's language, we can say type 1, type 2, type 3, type 4. But that is actually layman's language, or rather we can say grade 1, grade 2, grade 3. But I'm very much appreciative to my mentors who taught me midwifery. I'm very much appreciative to Madam Zipporah Jero. I'm also appreciative to Mrs. Mukundi and also Madam Sally Oroje, those who have impacted knowledge for me, and I'm here because of them. So let's go to the classification. We talk about type 1 or grade 1. It's also known as lateral placenta previa. The word lateral gives you the description where actually the placenta is located. And in this lateral placenta previa, we are saying it's referred to as lateral placenta previa because most of the placenta tissue are on the upper uterine segment. Only the lower edges of the placenta, they are actually found on the lower uterine segment. Then we say vaginal birth is possible to this one. So when you get a mother with lateral placenta previa, you as a midwife, you as a student midwife, you are not supposed to panic. Continue monitoring labor, continue conducting labor like how you normally do for the normal labor. There is no panic, there is no worry. Because heamorrhage is minimal and the fetal and maternal conditions are good, are very okay. They have not deviated from the normal. Then let's go to type 2. We are saying type 2 or grade 2 is also referred to as marginal placenta previa. And we are saying the greater part of the placenta is actually located in the lower uterine segment in such a way that the lower margin extends to the edges of the undilated cervical, internal cervical horse. Then when you check about the bleeding, bleeding is moderately, and there's so early features of fetal hypoxia, maternal shock. They can be resulted from prolonged bleeding. Therefore, we in type 2, in marginal, we are saying we normally have 2, whereby I want you like a student to go and differentiate by 2. Although we are saying in marginal or type 2, vaginal bleeding, it is possible. There is no worry again. It's like type 1. Manage this mother like in normal labor. And I've said in marginal, we have 2 classification, sub-classification. We have posterior and anterior. So I'm going to find out why do we say posterior. We need to take the mother posterior section, and then anterior we need to take mother can be conducted as a normal labor. Then we go to type 3 or grade 3. We are saying it's also referred to as complete placenta previa because placenta is located over the undilated cervical horse, though not actually centrally located. But here we have severe bleeding can occur as the segment starts to preparing for the labor progress. When we get a mother with type 3, This one don't allow normal delivery. Prepare mother for emergency cesarean section so that you can be able to save the life of the mother and the fetus, all both. Then we go to type 4. We are saying type 4 or grade 4 is referred to as central placenta previa because actually the placenta is centrally located over. The placenta is actually covering the internal cervical host completely. Therefore, it means that the baby cannot be delivered via in the placenta 4. Means that the mode of delivery is actually what? Cesarean section. Because bleeding again here is usually torrential. The mother is bleeding profusely. Hence, and automatically, we can be able to cause harm to both mother and the what? And the fetus. So basically, those are the 4 classification of placenta previa. The main words that you can be able to remember, it is what we call Lamassose. Lamassose. Lamacoce. So that one gives the 4 classification of placenta previa. That is lateral, marginal, complete, and central. In your free time, I would like you to go and see the diagrams of the placenta previa. How the placenta, when you talk about lateral, marginal, complete, and the central, how does it look like in your Margaret Myers? And we go and ask ourselves, what is the specific management of this mother with placenta previa? And we are saying management depends on key factors. That is actually the 4 factors in management. Number 1, it will depend on the amount of blood loss. Number 2, specific location of the placenta. Is it laterally? Is it marginally? Is it complete or is it centrally located? Then number 3, in management, it depends on the fetal and maternal conditions. Fetal conditions and maternal condition, basically this one will be able to get on the partograph. And we know what is a partograph is. And we are saying a partograph is a geographical tool that is used to monitor the progress of labor. And it's normal has what you call it has 3 parts. You need to go and conceptualize yourself with the partograph. What are the fetal parts condition? What are the maternal condition? And what is the progress of labor? So that when we are saying number 3 point, it's about fetal and maternal condition. Are you able to know what does it entail in the fetal condition, in maternal condition, and also in the progress of labor? Then number 4, it's about fetal maturity. In fetal maturity, and we are asking ourselves, in the fetal maturity, do we have other factors which are favorable in these regards to the fetal maturity? The other question you need also to understand is where is the mother? Is she in the BMOC facility or in a CMOC facility? BMOC facility, these are facilities which they do not have theater activities. Then CMOC facilities, they are equipped with what? Theater, lab, all those things that you can be able to take care. So if the mother is in a BMOC facility, prepare for emergency transfer to the CMOC facility using CBA methods. I'll come to teach those one again. Then we will talk about bleeding. We are trying to ask ourselves, is the mother, does she has slight bleeding or not at term? So those are the things that we need to be able to put into consideration. Or are we talking about moderate bleeding? Or further, is it severe bleeding? So those are the things that we need to be able to look at them. So go back in your books and read about the management. Complications of placenta previa, we are trying to get about several complications. You can either get about postpartum hemorrhage, and I'll come to teach a postpartum hemorrhage as an obstetric emergency. What does it mean? We also be able to get about things like puerperal sepsis. Why puerperal sepsis? This is due to urgency involved in saving the life of the mother and the fetus, and also the low placental side. You can also get embolism, either airway or amniotic fluids, when it is sieve into the maternal circulation, you can be able to get those embolism. You can also get increased perinatal mortality rate because of the severe separation, or actually severe fetal hypoxia. Or you can either get about severe birth asphyxia, or you can also get stillbirth of these babies. You can also get PPROM, that is premature rupture of membranes. Why PPROM? We are trying to address the reason of PPROM to occur in placenta previa is as a result of malpresentation, and malpresentation ends what we call intranatal infection to these babies. You can also get high maternal mortality rate due to anesthetic and surgical complications, also as a result of severe hemorrhage and sepsis. So that is basically about on the placenta previa. Briefly, let me talk about placenta abruption. And when I'm talking about placenta abruption, which we said it is the second common cause of antepartum heamorrhage, we can also refer and placenta abruption has accidental antepartum heamorrhage. Remember what we said? Placenta previa is referred to as unappointable antepartum heamorrhage. Now in placenta abruption is referred to as accidental antepartum heamorrhage. And we are saying by definition, what is it? This one we can say reverts to premature rupture, premature separation of normally situated placenta, and usually normally occurs at a gestation period of 24 weeks and also before the onset of second stage of labor. The placenta actually separates before the birth, before the delivery of the baby. What is the danger when this placenta normally gets separated before the onset of second stage of labor? We go back again and ask ourselves, what are the functions of the placenta? And I gave you a memoir of NESPA. NESPA means nutrition is going to be interfered, endocrine support, protection, excretion, and also respiration. Those 6 functions of placenta are going to be interfered with. So we go to predisposing factors to placenta abruption. Number 1, we are trying to talk about severe pregnancy-induced hypertension, which is also an obstetric emergency when we talk about eclampsia. There is sudden reduction of the uterine size. Like, for example, when we have a membrane when membranes prematurely, in most cases, like a polyhydramnios. These are motherly polyhydramnios. Then there's a reduction of what? The amniotic fluid. There is trauma to the abdomen, although it is rare, but due to assaults, mainly intentional, all fall from a mere accident, can cause separation of the placenta. All strenuous physical efforts affecting the abdominal muscles, hence transmitted to the placental site. Malpresentation management. Malpresentation is a term that is in terms of like a external cephalic fashion as you try to turn the baby. Let's say in abnormal labor, when the baby is presenting with a breech, then you want to convert breech to cephalic presentation, since it involves applying traction to the placenta unknowingly. Hence, you can be able to cause the placenta abruption. Then we talk about smoking. Mothers who are normally smoking during pregnancy. And we ask ourselves, what is the relationship between smoking and placenta abruption? This normally leads to what we call vasoconstriction due to effect of the nicotines. Therefore, I would like you, like students or like midwives, to go and to discuss or to read on yourselves about the pathophysiology of the placenta previa. Let me just talk about the types of placenta previa. In types of placenta previa, we are saying it's actually based on presence. That is number 1. Presence of blood or absence of blood. And when we are talking about presence or absence of vaginal blood loss, then the status of the fetus and the mother. What is the mother's condition? What is the fetal condition? So we end up by going to get three classification. We get what we call refilled, concealed, and mixed hemorrhage. Refilled means vaginal loss is observed, and then it is determined by the degree of separation. Then number two, we talk about concealed. Concealed means no vaginal loss. Mother has a lot of pain on the uterus when you are palpating on the uterus. Then the uterus is actually enlarged. Then there is a fear shock is actually much common on concealed as opposed to the opened. Then mixed, it means we have the combination of refilled and concealed, and some drainage while at rest is actually concealed. Therefore, in the classification of this one again is also based on the degree of separation. Therefore, we can be able to get mild, moderate, and also severe, those ones. Clinical features of placenta abruption, we are trying to talk about the color of the blood. In most cases, when you are talking about sealed, means the blood is not coming out of a vaginal loss. So we are trying to expect which type of blood. It means that this blood is just concealed inside the abdomen. So it is going to form what? Clots. And these clots are the one which we are saying, as you do abdominal palpation, the mother normally feels pain because of the presence of the clots inside the uterus. And therefore, if it is refilled this blood, what is the color of the blood? It is dark in color in most cases. Then we have said there is failure of the vaginal loss, that is blood loss, due to clots. And this normally brings about hypofibrinogenemia. Then there is also severe state of shock to this mother. There is enlarged and the extreme extension of the uterus on inspection. The abdomen is painful on abdominal palpation. There is inadequate supply of oxygen and the nutrients. Remember, we said the functions of placenta are going to be interfered with. Then on the location of the fetal parts, it's very difficult because of the severe pain and the muscle guarding expressed by the mother. Fetal heart sound is not easily located, and hypoxia is actually mostly commonly noted during this one. And in severe cases, you can get intrauterine fetal death. Therefore, it means you cannot hear what fetal uttered. Then when you just do abdominal the palpation, the uterus is very hard and the wood, which is collectively referred toward board-like consistency because of the severe damage of the uterus. So again, we are trying to talk about on diagnostic features. They are the same like the placenta previa. You need history taking, physical examination, and also radiological examination. Then in terms of the specific management to this mother, we are saying two aims on the specific management is to ensure live birth and finally prevent postpartum hemorrhage for this mother. So that is the management, and that is what I want you to go and read, the management of mother with a placenta abruption. I would like to tell you to go and a takeaway assignment, go and differentiate between placenta previa and the placenta abruption. This one is in regards to clinical features. Then when you get about complication of placenta abruption, you are trying to talk about Sheehan syndrome. Sheehan syndrome. And this occurs due to necrosis of pituitary gland, especially in the anterior lobe as a result of hypovolemia. So that's, you can get Sheehan syndrome. You can also get postpartum hemorrhage. You can also get dissemination intravascular coalition, which is characterized by massive hemorrhage from the body, from the all body orifices. Maybe the blood is coming from the anus, from the vagina, and so on and so on. In mild cases, you can present with failed lactation, that is amenorrhea, and severe cases with premature menopausal features. Finally, you can get, it's also common in moderate